We see anchor institutions as economic engines that have an embedded social mission that, because of the combination of those two items, are rooted in place within their communities. And the most common anchor institutions are health systems, which tend to be the largest employers in their communities, sometimes in their regions, and even sometimes in their states. The idea of the anchor mission is a North Star for how these large institutions that are inextricably linked to the well-being of their communities can more intentionally align their everyday business practices, their HR, their supply chain, their treasury, purchasing, hiring, and investing in order to more meaningfully impact the communities in which they serve and to really bring all of their resources to bear in addressing economic and racial inequities within their footprint. And one of those key strategies is place-based investing, which really looks at the long-term reserves that health systems and also universities have in terms of how they can take just a small percentage of that away from Wall Street and redirect it back into Main Street through low-interest loans, loan guarantees, and other types of investment vehicles that can really help catalyze and make community development projects within their community pencil out and the financing work. And so we're seeing a number of those creative strategies across the country, and most commonly they take the shape of housing, but they can also be support for small and diverse businesses or helping childcare centers or federally qualified healthcare centers, many different ways that this investment can be used to create community development projects within the communities they serve.
Community investment is financing, usually on favorable terms, for deals and projects that help improve the social, economic, and environmental conditions in underserved communities so that residents of those communities can lead healthier lives. But generally, when we talk about community investment, we're talking at least about a return of the principal amount that was invested. So Boston Medical Center, for example, has done some 0% loans to housing projects, to a grocery store. We've seen Common Spirit build a portfolio of about $100 million of loans, sometimes to developers, sometimes to these CDFIs, nonprofit banks. And we've seen Nationwide Children's Hospital, for example, provide a guarantee which lowers the risk of an overall transaction to a fund for affordable housing in their neighborhood that allowed other investors who had a more financial risk profile that was risk averse to come into those deals and participate.
Many of those are what we would think of as relatively advanced partnerships, where there's substantial financial resources changing hands, or really a deep commitment and really a system-wide or hospital-wide commitment to this type of work, which is really important. Lower or sort of earlier stages in this take the form of, we think of it as low or medium complexity, so sort of a preliminary or intermediate levels of engagement, which is really where a lot of healthcare systems or hospitals can start. Low complexity or preliminary, that might just be identifying and reaching out to local community development organizations that are in the neighborhoods where you see patients, identifying those neighborhoods of focus or pain points that you both might be interested in, joining an advisory group, having those representatives of those organizations join advisory boards of the hospital, or vice versa, serving on their advisory boards. Sharing data and data analysis capacity can be a really important tool for healthcare systems because they have the data that can help actually drive some of these investments. An early first stage is just actually putting healthcare resources into existing affordable housing. I think the focus really is on what are some of the steps that you can do without using actual dollars yet. So using the hospital's social clout and their political clout, so supporting local or state policies for increased housing, for example. And it's interesting, a lot of the community development resources, especially federal tax credits, are competitive. And so a healthcare system can actually weigh in and provide a letter of support saying this is important. This can make it more likely that a local community development organization can actually get those resources. And if you get a little bit more intense, this intermediate or sort of medium complexity, that's where it starts to reach a little bit more what Robin was talking about, which is providing community benefit dollars that actually accelerate some of this work, or identifying land or buildings that the hospital owns that aren't being utilized extensively. That can really speed up or allow a project to be more impactful in the community. And really, again, beginning to partner with some of these local community development financial institutions that are interested in doing the same work and creating healthier and more opportunity-rich neighborhoods.
So sometimes hospitals can provide grants and loans, and that's terrific. But we also see that, especially post-COVID, there are land and building opportunities that are not going to be utilized by the health system in the future, and providing donation of that land or long-term lease on favorable terms of that land for community purpose can really jumpstart an important community amenity or community project. So the land part can be really critical. Another role, for example, is a master lessor. So if there's a multi-use building that's being created, and the hospital can guarantee that it's going to take a certain amount of space on the ground floor for offices or a certain number of units for their employees or patients, that can really help a building get financing. So that's really important. Advocacy is really important, both with the public sector around policies, but also with potential investors, especially other employers. Hospitals have a lot of credibility in the business community, and so they can make the case to other corporate leaders for investment dollars, for advocacy causes, for policy changes or practice changes in the community. And they can be a data provider. Hospitals have to do a community health needs assessment every 3 years. That data can be really valuable in identifying health hotspots that might be able to benefit from community investment. So the data role is another one that can be very important. Well, what's been really interesting for us is that the financial and pure economic motive is certainly present, but it's really not the only reason or even the main reason that hospitals and health systems get into doing this work. What we've seen for some hospitals, whether they're faith-based or pediatric hospitals, is that a clear understanding of the importance of community conditions in creating health really matters to them. And so whether it's that they stand with the poor, or whether it's that they realize that if they're going to promote health and not just provide health care, that this is part of their job.
We've seen health systems move to focus on the social determinants of health. And I think for many of them, that has raised the question of how do we systematically address these social determinants of health? We don't have enough grant dollars to create the programs that will address many of these systemic issues. And what has been helpful for them around the anchor framework or the anchor mission concept is that it provides a way to look differently at the resources that an institution has and ask, how can we leverage our assets more intentionally? And so for many health systems, they might actually start with some of the other anchor strategies around hiring or purchasing, but the framework helps bring into the conversation more intentionally the role of investment, and really transforms the conversation from just talking about grants and donations to thinking more strategically about the pool of capital that many health systems have that can be paired with those grants and donations that have an even more catalytic impact.
These types of neighborhood investments are really a way to activate efforts to increase racial equity. And it's very easy to just talk about racial equity in a broad sense, but what does that really look like? And what we know is that a lot of the health disparities in racial groups is driven by the neighborhoods and the resources and infrastructure that exist in those neighborhoods. And using these sorts of community development investments and using some of the community benefit dollars to accelerate existing efforts, using the land or buildings that are owned to allow for a deal to move forward that might not, actually is effective in targeting low-income neighborhoods, communities of color, and increasing the racial equity that is often a stated goal of healthcare systems in the current environment. It's often driven by the CEO that perhaps personally and or the board that just sees the value in this type of work. And I think those are successful because you have the board, that you have the trustees, you have the CEO thinking about this from the top. I've also seen a lot of systems where it's high, mid-level employees that are, even if it's fairly widespread, meaning multiple components of the hospital are engaged and focused on this issue, it's important to have the C-suite part of the conversation relatively early on, because otherwise it can sort of die, these efforts can die on the vine.
It's really critical, especially at the early stage, to have a champion who's passionate about this. Mm-hmm. The higher up in the hierarchy that champion is, the easier the path forward gets. But having somebody who really cares about this a lot and is willing to punch their fist through the wall makes a big difference. And then we find over time that making this part of somebody's job, if not their whole job, is really critical to maintaining the momentum, because this is work. And if it's just somebody's extracurricular activity, then it tends to be a one-of and goes away. It really has to become institutionalized. I think one of the things that we've seen is that communities are not monolithic. And it's really important for health systems to get close enough to the communities that they're working in to be able to distinguish who agrees with who and who disagrees with who. So that may be neighborhood groups, it may be homeowners associations, it may be churches and other faith-based groups. Sometimes it's school-based groups and PTAs. It could be a community development corporation. The exact form that it takes varies from place to place. But hearing one voice and thinking that it somehow represents the community is a mistake that really is best to avoid. And so if there isn't somebody in the health system who has a really close, trusted relationship with the community, then figuring out how to develop that either through direct services or with a consultant or with somebody whose experience is engaging community is a really critical step, because otherwise the health system's understanding of what the community wants is unlikely to be exactly the community's perception of what they really want.
And I think very much to this conversation, healthcare leaders are thinking about what is their role in tackling some of these things. How do we improve the housing? How do we improve the quality of the schools? How do we get healthy food in these neighborhoods? How do we create community facilities or even healthcare facilities in these neighborhoods? And it's increasingly clear, especially through partnership through some of the community development financial institutions and local community development corporations, that you can do that not directly or by yourself as a hospital or healthcare system, but by accelerating the work of the organizations that are already there.
I think there is a real opportunity to look to the future in terms of the infrastructure to build. And in the same way that we're talking about how health systems should build that interdisciplinary table internally that brings together the different departments for a new conversation around how they can leverage their assets, I think the same opportunity exists at either the city, the county, or the region level to really create a table of anchors.
This is a moment of opportunity as we come out of the pandemic and as federal funds are flowing into these communities in unprecedented dollar amounts. There are a lot of projects that are going to happen that could really benefit from involvement by the health system. And there's a real opportunity to create lasting infrastructure in underinvested communities that we just have not seen before. So for health systems that are thinking about getting into it, now is really a terrific time to be getting mobilized, because it's going to make a huge difference over the next 5 or 10 years how thoughtfully executed those projects are.
So I think that the pandemic really further brought into focus the imperative for this work and how it is grounded and rooted in racial and economic inequities within our country, and that we need a systems framework and a systems approach to begin to dismantle those.
How do we take some of these resources and support or accelerate or expand investments in these neighborhoods that will create infrastructure that lasts long term and actually improve health and racial equity long term is going to be really important as we start to try to figure out how to spend these enormous amount of dollars.